Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. It is October 23rd, 2025. We're in the post-Esmo 2025 afterglow. One of the many problems with the APACs is that there's been less active scientists and physicians on there, and in the glory days of that app, I hear a lot about meetings going on, and there's much less of that going on now, so I haven't been able to get as much of the chatter from that, but do have quite a bit to talk about today. I sound a little different. My nice microphone, I left at home in the office, just run around like a chicken with my head cut off, as Kramer says in that one, or as Jerry says in that one episode of Seinfeld, when he switched places with Kramer, oh, I'm stressed. So let's get into LBA1, so late breaking abstract 1. This is what they would have thought is the biggest thing to talk about coming out of Esmo. And we actually have talked about, this is Destiny Breast 05, which was, the positive results of this study for trastuzumab deruxtecan were put out by the drug company, a few months ago. So we knew that these data were coming. And so this is HER2 amplified patients who receive neoadjuvant chemotherapy and they have residual disease, and instead of being, we know that trastuzumab emtansine has excellent benefit in these patients. So this is a comparing trastuzumab deruxtecan to trastuzumab emtansine. We have seen T-DXd outperform T-DM1, which is trastuzumab emtansine. In the second line and the metastatic setting, we've seen that. So it's not surprising that we're seeing what is a better drug continue to show benefit earlier in therapy. And so this is a large study, 1,600 patients, has not been published yet, so don't have all the details. But the primary endpoint was invasive disease-free survival, and the estimate is at 36 months that invasive disease-free survival is higher by 8.7% in the T-DXd arm compared to the T-DM1 arm. This is something that people should I think adopt now. It's been presented at the annual meeting. So if you're doing trastuzumab emtansine for those folks who've done neoadjuvant chemo with HER2 amplified disease, they go have surgery. There's residual disease there. Now we know 14 cycles every 3 weeks of T-DXd is probably gonna be better than T-DM1. So that's something that's approved, that's practice changing. Another study, this is LBA2, that I think is also practice changing, is Keynote 905. So this is perioperative Enfortumab Vedotin and pembrolizumab in bladder cancer, urothelial cancer that is cisplatin-ineligible. So we already know in the advanced or metastatic setting that Enfortumab Vedotin and pembrolizumab, that combination has supplanted platinum-based chemotherapy as the best treatment for those folks. So this is looking earlier in line of therapy, prior to radical cystectomy plus pelvic lymph node dissection. Now these patients are cisplatin ineligible, so they're not getting cisplatin. So according to the Galsky criteria, is what they use. They either have a performance status of 2 or higher, ECOG performance status 2 or higher, creatinine clearance above 60. Some could argue 50 is a reasonable cutoff there for cisplatin eligibility. Grade 2 hearing loss or worse, grade 2 neuropathy or worse, or grade 3 or worse, New York Heart Association heart failure. So these are cisplatin ineligible patients, which is to be fair, the largest population in bladder cancer, the bladder cancer population, because they are older patients. There are 3 arms on this study. There's a pembro only arm, which was not reported at ESMO. There's pembro plus Enfortumab Vedotin for 3 cycles, and every 3 pembro cycle, and then followed by surgery or straight to surgery. And so, the primary endpoint was event-free survival, and the 24-month estimate of event-free survival, so no disease recurrence, no death, no local recurrence, is 74% with Enfortumab Vedotin pembro versus 39%. That's a huge improvement in event-free survival. We also see, a statistically significant improvement. Overall survival hazard ratio, point estimate of 0.5, 95% confidence interval 0.33 to 0.74. The 24-month overall survival estimate, 80% with those 3 cycles of EV and pembro versus 63% those who went straight to surgery. So similar to what we saw with trastuzumab deruxtecan, this regimen is studied in the metastatic setting, now moving earlier into the curative setting, and we see that here. All right, let's keep talking about bladder cancer and talk about POTOMAC. No, not the big river, but the study, which was published in Lancet Oncology. This is Durvalumab, a PD-L1 targeting monoclonal antibody in combination with BCG for BCG-naive high-risk non-muscle invasive bladder cancer. And we're going to see the PD-L1 inhibitors making their mark here in urothelial carcinoma. So POTOMAC randomized patients 1:1:1 to either standard BCG induction and BCG maintenance for non-muscle invasive bladder cancer. I should have pointed out that in Keynote 905, those were muscle invasive bladder cancer patients. That's why they went to surgery or got the Neoadjuvant Enfortumab Vedotin and pembro. So these are in POTOMAC. These are non-muscle invasive bladder cancer patients. These folks get a TURBT, transurethral resection of bladder tumor, and then they get intravesicular BCG. There's an induction where it's like weekly for 6 weeks, and then maybe every month or a dose every 3 months. There are a lot of different maintenance site regimens, and BCG is really good. Causes a local, immune effect inside in the interior of the bladder. Cause all this immune activation. Really, one of our early forms of immunotherapy. So that was one arm, kind of the standard BCG treatment for maintenance. They were also then the experimental arm was pembro plus the same BCG, or pembro plus just induction BCG. These were all muscle invasive bladder cancer patients, non-muscle invasive bladder cancer. This is a pretty large study, 1,300 patients. And just to kind of to hit the high points here, because we have a bit to talk about. One, the Durvalumab. It's POTOMAC, right? It's a water study, so it's a large body of water, so it's a Durvalumab study. So Durvalumab plus BCG was better than BCG alone with regards to disease-free survival. We don't see an improvement in overall survival. Okay. It is also worth noting that there was one of the regimens here was Durvalumab plus just a little bit of BCG, just the induction BCG, where you just get a dose in the bladder weekly for 6 weeks, but then no maintenance. The arm that got Durvalumab plus BCG, but only the induction BCG, did not do as well. And so there is still importance for this induction and maintenance BCG. That's one of the low-key takeaways from POTOMAC. But we are keeping these patients without their cancer coming back locally for a longer period of time here by adding Durvalumab up front. And if we look at our disease-free survival at 12, 24, and 36 months, the improvement you see by adding Durvalumab is 4.9%, 4.9%, 4.4%. So we're not seeing, a big change over time, but we are seeing that change maintained. And again, we've got, pretty good follow-up here, with median follow-up, in the years here, and we're not seeing an overall survival benefit. Okay, so there becomes a, if you know that these patients, for example, are never going to be candidates for potential curative surgery, that would probably argue to be more aggressive upfront with Durvalumab in combination to the BCG. But we now know that for these folks that would go on, if they're not even cisplatin-eligible, that we do have this Enfortumab Vedotin and pembrolizumab data coming out now. Okay, staying in the same organ, in the bladder. There was a theme here at Esmo 2025 of circulating tumor DNA guided treatment. And so this is IMvigor 11 or IMvigor 011. In math, you don't need the 0 before the 11, but in for Roche or whoever, I don't know, you do need it. Okay, so this is from Tom Poles, who is the first author on all these GU studies. I don't know where does he find the time? So this is looking at patients who have had their 760 patients were enrolled, and they're looking at if you're ctDNA positive. So you test, they go and they have their radical cystectomy. And some of these patients, maybe I think it's about 40% actually had neoadjuvant chemotherapy, which would have been cisplatin based. So they could have had chemotherapy or not. Yeah, it was about 50 and 48% each arm had neoadjuvant chemotherapy, and they're getting the ctDNA from their plasma serially. And at the point it becomes positive, then they're randomized to either atezolizumab or placebo. Okay, and what we see here is the top line result here is the median OS was 32.8 months in those who got atezo, and 21.1 months who got a placebo in those who were ctDNA positive. We also see that if you were ctDNA negative for throughout the whole time, your disease-free survival was 95% at the end of a year and 88% at the end of 2 years. Now, because this was a prospective randomized controlled study, we have very good prospective data on the prognostic impact of ctDNA negativity here in bladder cancer patients. A couple things to point out about this study. The time of randomization is when you become ctDNA positive, which means there are some, you just can't look at that Kaplan-Meier curve and think, oh, this is from the time of surgery. No, it's from the time of ctDNA positivity. Now, most of those folks, 70%, that ctDNA positivity happened within 20 weeks of their cystectomy, but in 30% it happened, more than 5 months later. I will point out that we knew of these results because Signatera, I believe is the name of the ctDNA platform that was used. They put out a press release. Now, that Signatera was only done in non-mainland China countries. The sensitivity analysis, there are only like 25 people in mainland China who were ctDNA positive. But we also have some good now idea of what is the difference as far as clinical characteristics of people who are likely to be ctDNA positive. So, for example, those patients who were ctDNA positive, about 58% were node positive. Those who were persistently ctDNA negative, only 20% were node positive. Again, T3 or T4 disease, more likely to be ctDNA positive. The other thing that makes it hard to extrapolate an atezo study from some of the other immune checkpoint inhibitor studies is they use a different staining system for PD-L1, looking primarily at immune cells. So IC2, IC3 was about a third of the patients here in this study, which is not really analogous to like your tumor proportion score at all. We do see an improvement in disease-free survival. We see an improvement in overall survival. The median follow-up here was 16 months, so if we look at a 16-month estimate of overall survival, it's 80% versus 65%, favoring those folks who got atezolizumab. So this is looking pretty good, and we're getting smarter about figuring out who should get this sort of, it's not necessary, it is adjuvant, but it's not adjuvant for all people. And atezolizumab has a pretty checkered history in the urothelial carcinoma space. There's approval, the approval was restricted, it was withdrawn. And if they had just gotten an approval, like if they had just done their study a little bit differently or gotten a little bit lucky, we might have an approval for atezolizumab. But because it was negative, the people making atezo had to keep trying to find a way to justify the use of their drug in this patient population, and we end up with what might be the way to use these drugs, immune checkpoint inhibitors, in the adjuvant in the future, which is using ctDNA-guided monitoring. Now, one thing that I would have loved to have done had I had time is go back and look at the early days of tumor markers. We were measuring like CA19-9 to monitor progress of people with pancreatic cancer, for example, and how those studies were done. Because we don't look at tumor markers and then we have phase 3 data saying that when it goes above this high, we necessarily do treatment. We might get to that with ctDNA. All right, keeping along the ctDNA-guided treatment, we have the Dynamic 3 trial, which was a phase 2-3 study published in Nature Medicine, which is not a place you typically see this type of clinical study published. So this is a study of stage 3 colon cancer patients. Now, it's a relatively small study to be, I'll put it this way, a practice-changing study for phase 3 colon cancer is probably going to be pretty big. This was fewer than 1,000 people. And they're looking ctDNA-guided adjuvant treatment. It's It's not a drug company studied or drug company sponsored study. It's from some groups from Australia and New Zealand. And their primary endpoint is looking at 3-year recurrence-free survival in those who are ctDNA negative, or 2-year recurrence-free survival in those who are ctDNA positive. So the way that this study was done is these stage 3 folks with colon cancer, it was decided upfront by their oncologist what would be our adjuvant treatment. And that could be 6 months of fluoropyrimidine. It could be 3 months of Capox or Folfox. It could be 6 months of Capox or Folfox. And that's decided upfront based on things like the patient's performance status and their disease characteristics. And then they're monitoring ctDNA to either de-escalate therapy or escalate. So you might imagine somebody starts, we're going to do 6 cycles of Capox, okay? We do 6 cycles of Capox, our ctDNA comes back negative, we feel better about the patient's chance of cure, so we de-escalate and we drop the oxaliplatin, okay? That's kind of what a big part of this study is. The other part of this study is, you become ctDNA positive. Well, I was going to do 3 months of Capox, I'm going to escalate to 6 months of Capox, okay? Kind of makes sense intuitively what they're doing here. Well, we've got a median follow-up of about 47 months, and those who were ctDNA negative they did better. They had fewer relapses. The 3-year relapse-free survival was 87% if you were ctDNA negative versus 49% if you're ctDNA positive. All right, and that's prospective data. I feel really confident that's probably going to be accurate everywhere else. Now, if you're ctDNA negative and your provider de-escalated your treatment, you had a lot less oxaliplatin use, 35% versus 89%. Fewer hospitalizations, 85% versus 13%, right? So we're thinking, all right, much less toxic. We're giving less drug. The obvious question is it still as good? And unfortunately, the 3-year relapse-free survival rate was 85% in the de-escalation versus 88%. Sorry, this is 2-year relapse-free survival rate. 85% with de-escalation compared to 88% with standard. And our the non-inferiority margin here was 7.5%, and the total difference there is 2.8%, and the 95% confidence interval is -8% to 2.3%. So our -8 is lower than -7.5. So this was not non-inferior. And the last take-home point here, persistent ctDNA after treatment had a much worse prognosis, right? So if you finished your adjuvant chemotherapy and still has ctDNA, only 14% of those folks were alive without disease recurrence 3 years later versus 79% if the ctDNA was negative at the end of treatment. Now, one of the things that muddies this is it's not just 6 cycles of Capox and then we're de-escalating to 3 cycles or 3 months of Capox, or we're de-escalating to just 6 months of fluoropyrimidine. Every patient had an individualized adjuvant plan before the ctDNA is measured, and I think that's appropriate for the real world. But it does, especially when you only have 350 people in either arm here, the standard or the de-escalation. We're not going to get as clean of data and as an obvious answer here. It does provide us a lot of good prognostic evidence about what we know. I don't think that this is necessarily going to be practice changing. I would love to see a larger study repeat this with, we have a known plan that we're going to do, like 6 months of Folfox for those people, and we're going to de-escalate to 3 months of Folfox and then drop the oxaliplatin at 3 months and continue 3 months of fluoropyrimidine. Or we're going to do, we're going to plan for 3 cycles of Folfox, Capox, and then de-escalate to just 3 months of fluoropyrimidine. But it's a little bit different, and so we can see or get an idea here is that in the standard management, only 9% got 6 months of single agent fluoropyrimidine, but that was 24% in the de-escalation strategy. 41% got 6 months of Folfox or Capox versus only 2% in the de-escalation. So what this tells us is even if you have folks that are ctDNA negative, in this study at least, they probably de-escalated a little bit too much, and maybe we need either better ctDNA-guided treatment, or we need some serial ctDNA negativity times more than 1 before we de-escalate. All right, the last thing I'm going to talk about here is Harmony 6, and this is ivonescimab plus chemo versus atezolizumab plus chemo for the first-line treatment of advanced squamous cell carcinoma of the lung. Ivonescimab was a drug that I've talked about before because it's a unique drug. It's not FDA approved yet. It's only been studied in China, and in the past, FDA has been a little cautious about approving drugs only studied in one country versus an international study, including study here in the U.S. So anyway, this is a positive study. The thing that's interesting about this drug that I did not appreciate is it is a bispecific antibody. So this drug targets VEGF and PD-1, but does so in a very, very different way. All right, and there is some wonderful images here, and this is called tetravalent structure and cooperative binding. So if I do my analogy where I stand up straight, put my arms in the air, where my left hand and my right hand, the FAB fragments, when we talk about a bispecific monoclonal antibody, usually that means the left hand binds to something else than the right hand does. So what you might think if you read ivonescimab as a bispecific antibody is the left hand binds to VEGF, right hand binds to PD-1. That is not what happens. The left hand and the right hand bind to VEGF. And VEGF apparently is circulating in dimers. So what that means is one antibody, a left hand binds to a VEGF dimer, and then on the other side of that dimer, it binds to the right hand of a different antibody. And now the feet, where the FC portion will be, bind to PD-1. And what this does is add some added, what they call it, cooperative binding. So some additional, not only are you sucking up all the VEGF, but some more complete blockade of PD-1. And that is the theory here. So that's one thing that's really interesting. Now, we have seen this drug outperform pembrolizumab in the single agent setting in non-small cell lung cancer. That was Harmony 2. Did not get FDA approval from the FDA, at least as of now. And in case you do not remember, atezolizumab is an immune checkpoint inhibitor a la nivolumab or pembrolizumab. The other thing that is notable about this is, this ivonescimab does block VEGF and prevents that ligand from binding to the VEGF receptor. And that anti-angiogenic effect, we know from prior studies in non-small cell lung cancer that if you give bevacizumab plus platinum-based chemotherapy, you improve the median overall survival from like 10 to 12 months in this, I call it the A. Sandler study. Probably for like 2006-ish New England Journal of Medicine. Now, from that study, we learned that it is not safe to give bevacizumab to patients with squamous cell carcinoma of the lung because of a non-zero risk of fatal hemorrhage. These patients had that risk as well, but they don't report grade 5 side effects here. And so maybe that means there are none. 17-18% did have disease around a major blood vessel. But the hemorrhage rate was 21% with ivonescimab versus 9% in the atezolizumab group. So we did not apparently, with what's published, see that the potential fatal risk of bleeding by having a drug that blocks the effects of VEGF in squamous cell carcinoma of the lung. So something to follow. It's an interesting drug. It's a monoclonal antibody unlike anything else we have because of this cooperative binding and how it works in a different way than what we think of. And actually these antibodies kind of work better in tandem than one another. So just one ivonescimab antibody is not going to do a whole lot. It needs to work with others to have this cooperative binding effect, to have more complete blockade of PD-1 and allows that because of the VEGF dimers and how this antibody works. Interesting drug. So that is what I have. There was obviously more and more that I could talk about from Esmo, but did not have time to get into all of it, so tried to pick the stuff that I thought was most interesting and or practice changing. So that's what I have for this week. Thank you all for listening. You can follow me on that X at PharmDetenib and other social media platforms at UnclePharmPod. And until I talk to you again, remember, doses matter.